Welcome back to the deep dive. Today we are opening a file that sits on the desk of almost every family in the world at some point.
It really does.
We're talking about breast cancer.
Yeah.
But usually when we talk about this, the conversation is just dominated by fear. It's all pink ribbons, survival statistics, and this general sense of anxiety.
And that anxiety is completely understandable. It's a massive topic. But looking at the research we have today, this really comprehensive medical overview on oncologic disorders, well, we have a chance to do something a little different.
Okay.
We can unpack the logic of the disease.
That is exactly the mission today, to move beyond the headlines and really understand breast cancer not just as a condition, but as a complex landscape.
Right.
It has biology, these intricate staging systems, and what is basically a form of strategic warfare against cellular malignancy.
Strategic warfare is the perfect way to frame it. It really is. Because when you look at the source material, you realize breast cancer isn't just, a lottery of bad luck. It's a biological process. It has rules. It has a strategy for how it grows and spreads. And the modern medical response is this highly calculated counter strategy.
And as I was reading through this, I realized that breast cancer isn't just one thing. It's not a lump.
Not at all. It's a massive spectrum.
So that's the most critical starting point then for anyone listening.
Absolutely. We are looking at a malignancy that starts in the breast tissue, yes. But the behavior of that disease ranges from what we call curable early disease.
Where the goal is just total victory.
Total victory, wipe it off the map completely, all the way to treatable metastatic disease, where the entire strategy shifts.
It shifts to management.
To management and longevity, exactly.
And I think that distinction is the why for our deep dive today. We want to explain why two people, maybe two friends, two neighbors, can both get that diagnosis, breast cancer, yet their lives look completely different.
Completely.
One gets surgery and goes home. The other is on a pill for 5 years. The third is getting chemotherapy before anyone even touches the tumor.
And it can feel so random to the patient, but it's not. It's highly specific to the biology of their tumor.
Right.
By the end of this, we're going to decode that jargon, the ERPR, HER2, adjuvant, neoadjuvant, so you can actually understand the thinking behind those different paths.
Okay, so let's start at the very beginning, the basics, the enemy itself. The text makes a really clear distinction right away between early and advanced disease. What is the actual dividing line there?
The dividing line is basically location and extent. Simplistically, you have early or primary or localized disease.
Okay, localized.
This is when the cancer is confined to the breast lesion itself and maybe the local lymph nodes in the axilla of the armpit.
So it's still in its own neighborhood.
It is. This is the realm of curable. The goal here is total eradication.
And on the other side of that line?
Then you have advanced or metastatic breast cancer. You'll often see it abbreviated in medical notes as MBC. This is when the disease has been detected, either clinically or on a scan, in sites that are distant from the breast.
And when you say distant, you don't just mean the other breast or the muscle right next to it.
No, not at all. We are talking about the cancer having traveled and set up shop somewhere else.
Somewhere like?
The common places are the bone, the liver, the lungs, or the brain. And the text is very honest here. It states that once it reaches that stage, metastatic disease is usually incurable.
Incurable. That's a heavy word.
It is. Treatable, yes.
Yeah.
Manageable, absolutely. But usually not curable in that traditional sense of being gone forever.
That's a tough realization, but I guess understanding it helps explain why early detection is pushed so aggressively.
It's everything.
So how does it actually get there? I think people imagine it just growing bigger and bigger until it sort of bumps into other organs, but there's a more specific transport mechanism, isn't there?
There is. There are three main routes of spread. The first is what you describe. It's called contiguity.
Contiguity.
Which is just a fancy way of saying direct growth. The tumor gets bigger and pushes its way into the muscle or the skin. That's the bumping into things method.
Right, the brute force approach.
Exactly. But the more insidious routes are the highways. The second route is through the lymph channels, and the third is through the blood.
So the blood and the lymph systems are the cancer's transport network.
They are. And the scary part, and this is why we screen asymptomatic women, is that breast cancer cells can often spread undetected by these routes really early in the course of the disease.
Before you even know you have it.
Way before. They can be microscopic hitchhikers leaving the breast before the primary tumor is even large enough for you to feel.
Which explains so much. It explains why a metastatic site might show up years later, or why we treat the whole body even when we only see a lump in one place.
That's the logic behind systemic therapy.
Okay. So before we get into treatment, let's talk about risk. Who is actually at risk here? We hear so many myths: deodorants, bras, cell phones. What does the clinical data actually point to?
The data clears away the noise pretty quickly. The two absolute biggest variables are ones you have zero control over: gender and advancing age, simply being a woman and getting older. Those are the strongest associations with developing breast cancer.
Okay, can't change those. But then the text gets into what it calls endocrine factors.
Yeah.
And this section was fascinating to me because it all seems to point to one specific culprit:
Estrogen.
estrogen.
It's all about what we call the estrogen window. You have to think of estrogen as a kind of fuel. It promotes cell division in breast tissue. So the longer your body is exposed to that fuel, the higher the risk.
Okay, the estrogen window. Let's break down the specific factors listed in the notes because they all seem to connect back to this fuel concept.
Sure. So first, early menarche, that means starting your period at a very young age.
Right.
Second, late menopause, meaning you stop your period very late in life. Both of those scenarios just stretch out the window of time that your breast tissue is bathing in estrogen.
It extends the exposure.
It does. And then you have the pregnancy-related factor.
Yeah, this was interesting. Nulliparity.
Nulliparity. It's the medical term for never giving birth or having your first child at a late age.
Why do those matter? What does pregnancy have to do with it?
Because pregnancy interrupts that constant estrogen cycle. It gives the breast tissue a break from that monthly fluctuation and proliferation. So never giving birth means the engine has been running on that specific fuel without a break for decades.
That makes perfect sense. And of course, that would have to include external sources of hormones, like hormone replacement therapy.
Exactly. If you're adding more fuel to the tank after menopause through medication, you are artificially extending that window of risk.
Then, of course, genetics.
Yeah.
We can't talk about this without mentioning BRCA. It's probably the most famous acronym in all of cancer genetics.
It is, BRCA1 and BRCA2. But most people don't really know what those letters actually stand for or what the genes do.
They just know it's bad.
Right. But these are tumor suppressor genes. I always tell people to look at the name. Their job is to suppress tumors. They are the brakes on the car.
That's a great analogy, the brakes.
So when you have a mutation in BRCA1 or 2, it's like the brake lines are cut. You lose that natural protection against DNA errors. So if a cell starts dividing wrongly, the gene that is supposed to step in and stop it, it doesn't work.
And that leads to a much higher risk.
A significantly higher risk of breast and also ovarian cancers.
And we shouldn't forget environmental factors. The source material mentions radiation specifically.
Yes, radiation exposure, particularly to the chest area at a young age. For instance, if someone was treated for lymphoma as a teenager with radiation, that drastically increases their risk for breast cancer later in life.
So knowing the risk is one thing, but detection is another. The source describes the classic clinical presentation of breast cancer. And it's vivid. It's not just a lump. It has specific characteristics.
It does. The classic presentation is a painless lump. And that painless part is really key because people often ignore it. They think, well, if it was cancer, it would hurt.
But it usually doesn't.
Not at first. And a malignant mass, it typically has a personality. It's solitary, meaning just one. It's unilateral, so usually on one side. It's solid, it's hard, it's irregular.
And crucially, the text says it's non-mobile.
Non-mobile. That is a massive red flag.
What does that feel like?
Well, if you have a benign cyst, it often feels kind of squishy or it moves around like a grape under the skin. You can push it. A malignancy feels rooted. It feels fixed to the tissue around it like it's grabbing on.
And if the cancer is more advanced, what do you see then?
Then you start to see skin changes, edema, which is swelling, redness, warmth. The text mentions peau d'orange, which literally means skin of an orange.
Like with the dimples.
Exactly, like the peel of an orange. These are signs of inflammatory breast cancer or, very advanced disease, which is extremely aggressive.
But, and this is a huge but for anyone listening, we do not want to wait until we feel a hard, fixed, non-mobile lump.
Yeah.
That is not the goal of modern medicine.
No, absolutely not. Waiting for the lump is the old way. That implies the cancer has already grown to a significant size.
So the whole game has changed.
The whole landscape of detection has shifted fundamentally. While many women do still find abnormalities themselves, the gold standard now is detecting cancer in asymptomatic women.
Through screening.
Through routine screening mammography. We want to find it when it is a tiny speck on a scan, long before it ever becomes a palpable lump.
Because the earlier you catch it,
the more curable it is. It's that simple.
So let's say you go in for that mammogram and they see a speck. What's the workflow from there? What happens next?
It's a cascade of confirmation. It starts with your history and a physical exam. Then you get a diagnostic 3D mammography.
Which is different from a screening one.
It's more detailed, more focused views. If that's still suspicious, you might move to an ultrasound or an MRI to get a better look at the borders and the consistency of the lesion. But, and I cannot stress this enough, you cannot diagnose cancer with a picture.
You can't. Not even with a super high-tech MRI.
No. You can suspect it very strongly. A radiologist can say this has all the features of a malignancy, but the only way to confirm it is a biopsy.
They have to get tissue.
You have to get tissue. You have to put actual cells under a microscope and have a pathologist, a doctor who specializes in this, say, yes, these are cancer cells.
Okay, so the biopsy is done. The call comes in. It's positive. Now we enter the world of staging. This is where I think people get really confused. We hear stage I, stage 4V, TNM. It feels like alphabet soup. Can you help us decode this?
It is a code, but it's a very logical one. The TNM system is the universal language of cancer staging.
TNM.
T stands for tumor size. N stands for node involvement, meaning the lymph nodes. And M stands for metastasis.
Okay, TNM. Let's walk through the stages using that framework, because this really dictates the entire treatment plan.
Okay, so you start at stage 0. This is what we call carcinoma in situ.
In situ.
It literally means in place. The cancer cells are there, but they haven't invaded the basement membrane. They haven't broken out of the milk duct or the lobule where they started. They are contained.
So theoretically, this should be 100% curable.
An extremely high cure rate, yes. The cancer hasn't learned how to travel yet.
Okay.
Then you move to stage 1 and stage 2. This is what we call early breast cancer. The tumor is now invasive, it has broken out, but it's still relatively small. And maybe there's a tiny bit of lymph node involvement, but it's all still considered a local problem.
Then we hit stage 3.
Stage 3 is locally advanced. This is sort of the gray zone. This is usually a large tumor, maybe 5 centimeters or more. Or you have extensive lymph node involvement. Maybe the tumor is physically fixed to the chest wall.
So it's serious.
It's very serious, and it requires aggressive, multimodal treatment, but we are still treating it with curative intent.
And finally, stage 4.
Stage 4 is metastatic. The M in TNM is basically a 1. It means the cancer has spread to distant organs.
So staging tells us where the cancer is and how much of it there is. It's the geography of the disease.
That's a great way to put it. It's the geography.
But the source material makes a really interesting distinction here. It says staging is different from prognostic factors.
Right. Yes. This is a very nuanced point that patients and sometimes even doctors can gloss over. Staging tells us the anatomy of the disease. Prognostic factors tell us the biology of the disease, the personality of the tumor.
I like that. So staging tells us how big the army is, but prognostic factors tell us how aggressive the soldiers are.
That's a perfect analogy. You could have a small army of very aggressive soldiers or a large army of really lazy ones, and that makes a huge difference.
So what are the key factors that tell us about that personality?
Well, the number one factor for recurrence risk is the lymph nodes, the number of involved axillary nodes. The more nodes that have cancer in them, the higher the risk that the cancer has already traveled elsewhere.
So that's its potential to spread.
It's your primary indicator of spread potential, yeah.
Okay, so that's the risk of it moving. What about the fingerprint of the cancer cell itself? We always hear about ER and PR.
Right. Estrogen receptors, ER, and progesterone receptors, PR, these are hormone receptors. Think of them like little docking stations on the surface of the cell.
Docking stations.
And if a tumor is ER-PR positive, it means the cancer cells have these receptors that lash onto estrogen and use it as fuel to grow.
So knowing this tells us
Yeah.
what? Does it tell us if the patient is going to survive?
Interestingly, ER-PR status on its own isn't a super strong prognostic marker. It doesn't just tell us if you'll live or die, but it is a massive predictive marker.
Predictive of what?
It predicts whether or not you will respond to endocrine therapy. If your tumor has the receptor, we can use drugs to block that receptor. If it doesn't have the receptor, those drugs are completely useless.
It's like knowing if the enemy tank runs on diesel. If it does, we can cut off the diesel supply. If it runs on solar power, cutting the diesel line does nothing.
That is exactly it. It guides our weapon choice. And then you have HER2/neu.
HER2/neu. This one always sounds scarier in the literature.
It historically was, no question. HER2 is a protein that's associated with the transmitting growth signals. If a tumor has HER2 overexpression, it's like the gas pedal is stuck to the floor.
So the cells just divide uncontrollably.
Rapidly. It's associated with increased tumor aggressiveness, higher rates of recurrence, and historically higher mortality.
That sounds really bad.
It was bad. But, and here is where science is just amazing. Because we identified this specific protein, we were able to develop drugs to specifically target it.
Ah,
So while HER2 positive tumors are biologically very aggressive, they are also now highly treatable because we have a specific target to aim at.
that's the targeted therapy we hear so much about.
That's it. A drug called trastuzumab, brand name Herceptin. We'll get to it in the treatment section, but it absolutely changed the game.
And finally, the text mentions genetic profiling tools.
Right. These are commercial tests that look at the activity of a panel of genes inside the tumor itself.
And this helps. How?
It helps us refine our decisions.
Yeah.
For some subgroups of patients with, favorable features, these tests can help us decide if they can safely skip chemotherapy.
Wow. Okay, so we have the MAP, which is the staging, and the personality profile, which are the prognostic factors. Let's talk strategy. We're moving into segment 3. The strategy for early breast cancer. And the source says the goal here is curative intent.
Correct.
We are going for the win.
We are trying to eliminate the disease completely. And the strategy rests on 2 main pillars: local regional therapy and systemic adjuvant therapy.
Let's break those down. Local regional sounds like it means dealing with the tumor right where it is.
Exactly. That's surgery and radiation.
Okay, so surgery. The source lays out this huge debate that patients often face. Breast-conserving therapy, BCT versus mastectomy.
Right. So BCT is removing just the lumpectomy plus checking the lymph nodes, followed by radiation. Mastectomy is removing the entire breast.
Now, I think a lot of people just intuitively assume mastectomy has to be safer. Just take it all off and I'll be safe. If you leave breast tissue behind, aren't you just leaving risk behind?
That is a very, very common misconception. And it makes intuitive sense, but the biology disagrees. The data from massive clinical trials is crystal clear.
And it says,
Breast-conserving therapy is preferable to modified radical mastectomy because the survival rates are equivalent.
Equivalent. That just seems so counterintuitive.
It does. But you have to remember, the risk to your life isn't the tumor in the breast. It's the microscopic cells that might have already escaped to the liver or the lungs.
No.
Removing more breast tissue doesn't change what has already escaped. So as long as BCT is followed by radiation to clean up the local area, your chances of long-term survival are the same as if you remove the whole breast.
And obviously BCT offers cosmetically superior results.
A huge difference in body image and recovery. It's much less disfiguring.
You mentioned BCT must be followed by radiation. Why is that part non-negotiable?
Because with a lumpectomy, by definition, you're leaving breast tissue behind. And you might be leaving microscopic disease behind in that surrounding tissue.
You can't see it with the naked eye.
No. So radiation therapy is given to the entire breast, usually over 4 to 6 weeks, to eradicate any of those microscopic leftovers. It's the cleanup crew. If you skip radiation after a lumpectomy, the recurrence rates in that breast just skyrocket.
What are the side effects of that?
Mostly local, reddening of the skin, almost like a bad sunburn, and sometimes some shrinkage or firmness of the breast mass over time.
What about the lymph nodes? You said they're the superhighway for spread. Do we just rip them all out to be safe?
We used to. It was called a full axillary dissection. We would just clear out the whole armpit.
And the problem with that?
A lot of complications, specifically something called lymphedema, a chronic, painful swelling of the arm because the lymphatic fluid can't drain properly anymore. It can be debilitating.
So how do we avoid that now?
We use something much smarter called a sentinel lymph node biopsy. We inject a dye near the tumor and see which lymph node it drains to first. That's the sentinel.
The guard at the gate.
Exactly. We remove just that 1 or 2 nodes. If they are clean, we assume the rest are clean and we just leave them alone. It spares the vast majority of women a lifetime of arm swelling.
That's a huge quality of life improvement.
Yeah.
Okay, so the surgeon cuts out the lump, the radiation zaps the area, the cancer's gone, right? So why in the world do we then put people through chemotherapy? This is the systemic adjuvant therapy part.
This is the question every single patient asks. You got it all, the margins were clear, why do I need poison?
Yeah.
The answer is one word: micrometastasis.
Micrometastases.
Invisible, undetectable cells that may have broken off and traveled through the blood before the surgery ever happened. Surgery can't reach them. Radiation can't reach them because they aren't in the breast anymore.
They could be anywhere.
Anywhere the blood goes. So we need a treatment that also goes everywhere the blood goes. That's systemic therapy. The goal is to improve disease-free survival and ultimately overall survival.
So it's basically an insurance policy.
A very aggressive but very effective insurance policy. We usually start chemotherapy within about 12 weeks of surgery. And the source highlights a really important concept here called dose density.
Yeah, I saw that term, dose density. It sounds technical. What does that actually mean for the patient experience?
This is a great example of how we've learned to optimize treatment. Historically, we gave chemo, say, every 3 weeks.
Yeah.
You get a dose, you feel terrible for a week, you recover, your white blood cells come back up, and then you get another dose.
That sounds logical.
It is, but what we learned is that in that recovery time, the tumor can actually start to regrow.
It takes advantage of the break.
It does. It's called kinetic resistance. So dose density means giving the drugs closer together every 2 weeks instead of 3, often with the support shots to keep the white blood cells up.
So you're hitting them again while they're still down.
Exactly. You're decreasing the time between cycles to prevent that tumor regrowth. And it has been shown to improve survival, particularly in node-positive patients.
What are the drugs themselves?
We usually use combinations. The text mentions the 2 main classes: anthracyclines like doxorubicin or epirubicin, and taxanes like docetaxel or paclitaxel.
And these are the heavy hitters.
These are the heavy hitters. They work by damaging the DNA of the cancer cells or by freezing their internal structure so they can't divide, but they come with the toxicities people think of:
Hair loss, nausea.
hair loss, nausea, nerve damage, fatigue. But again, you have to remember, the goal here is cure. We accept that toxicity for the sake of a life.
Now, we mentioned HER2 earlier. This is where the biologic therapy comes in. This isn't chemo, is it?
No, it's totally different. It's a monoclonal antibody called trastuzumab, or Herceptin. If that tumor is HER2 positive, we add this drug to the chemotherapy.
And how does it work?
It's a smart drug. It attaches directly to that HER2 protein we talked about, and it does 2 things. It blocks the growth signal, and it also flags the cancer cell for the body's own immune system to come and attack it.
The source notes a statistic here that just blew my mind. It says this drug reduces the risk of recurrence by up to 50%.
50%. In the world of oncology, that is a staggeringly high number. It's a home run. It completely revolutionized the treatment of HER2 positive cancer. It turned what was a very scary diagnosis into a very manageable one.
Are there any questions left about it?
Oh, sure. Unanswered questions remain about the optimal duration and sequencing, but its impact is just undeniable.
And then, for the ERPR positive crowd, the ones whose tumors eat estrogen for fuel, we have endocrine therapy. This is the long haul, right? This isn't a few months of treatment.
No, this is years, usually 5 to 10 years of a daily pill. And there are 2 main categories of drugs depending on where you are in your reproductive life.
Okay.
If you are premenopausal, your ovaries are still working, the gold standard for about 30 years has been a drug called tamoxifen.
Tamoxifen. How does it actually work?
It's what's called a SERM, a selective estrogen receptor modulator. It basically sits in the estrogen receptor of the cancer cell, and it blocks the estrogen from getting in.
It's like putting a broken key in the lock.
That's a perfect analogy. The door won't open, but the real key, which is estrogen, can't get in either.
But the word selective in there is interesting.
It's the key word, because it blocks estrogen in the breast, but it actually acts like estrogen in other parts of the body, like the bone. So while it's starving the cancer, it's also helping to keep your bones strong. It reduces fractures.
That's a great side effect. A win-win. But surely there's a catch.
There is always a trade-off in medicine. It can also act like estrogen in the uterus, which slightly increases the risk of endometrial cancer. And it causes menopausal symptoms, hot flashes mainly, plus a small risk of blood clots.
Now, what if you are postmenopausal? The strategy changes completely.
Drastically. If your ovaries are shut down, we don't use tamoxifen first line anymore. We use a class of drugs called aromatase inhibitors, or AIs.
Like an anastrozole, letrozole.
Exactly. Anastrozole, letrozole, exemestane.
Why the switch? What do they do differently?
Because after menopause, you don't really make estrogen in your ovaries anymore. You make it by converting other hormones, androgens, into estrogen in your fat and muscle tissue. An enzyme called aromatase does that conversion.
So these drugs...
These drugs inhibit that enzyme. They shut down the factory that makes estrogen in postmenopausal women.
So tamoxifen blocks the receptor, the lock on the door, but AIs stop the production of the fuel entirely.
Precisely. They are more effective in postmenopausal women, but their side effect profile is totally different.
How so?
Because they deplete estrogen from everywhere in the body, AIs cause bone loss and can lead to osteoporosis. They can also cause significant muscle and joint pain, what we call myalgia. So the choice of drug really depends on where the woman is in her life.
It's a very sophisticated balance. Bone protection versus bone loss.
Hmm.
Clot risk versus muscle pain.
That is the art of oncology, tailoring the weapon not just to the tumor, but to the patient sitting in front of you.
Okay, so that was early stage. The goal is cure. We accept the side effects for the win. Now we need to shift gears into segment 4. Locally advanced and metastatic disease. Let's start with locally advanced stage 3. The source mentions a strategy shift.
Yes. So in stage 3, the tumor is big. Maybe it's stuck to the chest wall. Maybe it's too big to operate on cleanly right away. So we use neoadjuvant chemotherapy.
Neoadjuvant. Okay, that means chemo before surgery. Why switch the order?
There are a couple of really important reasons. First, to shrink the tumor. We want to make an inoperable tumor operable. Or we want to shrink a very large tumor down enough so that the woman can have breast conservation, a lumpectomy, instead of needing a mastectomy.
So you use the chemical warfare to shrink the enemy lines before you send in the ground troops, the surgeons.
Precisely. And the second reason is information. It's a test. If we give the chemo while the tumor is still in the body, we can watch it. We can see if it's working.
We can see if it's shrinking.
Right. If the tumor melts away, we know that drug is effective against that person's cancer. If we cut the tumor out first and then give chemo, we're kind of flying blind. We never really know if the chemo we're giving is killing those microscopic cells or not.
That's a crucial feedback loop. Now for the hardest part of this discussion, stage 4. Metastatic breast cancer. The source is very clear. The goal shifts from cure to palliation.
It's a profound shift, psychologically and medically. In stage 4, the cancer is in the bones or the liver or the lungs. We cannot cut it all out. We can't zap it all with radiation.
So it's no longer about eradication.
It's not. We now treat it like a chronic condition, like diabetes or hypertension. The goal is to prolong survival and, just as importantly, optimize quality of life.
Optimize quality of life. That phrase does a lot of heavy lifting.
It drives every single decision we make. In early stage, we accept high toxicity, hair loss, vomiting, nerve damage for a chance at a cure. In metastatic stage, we actively avoid toxicity.
You want the patient to feel good.
We want the patient to feel good for as long as possible. So we always use the least toxic therapy first.
So if a patient has hormone receptor positive metastatic cancer, you don't blast them with chemo right away.
Absolutely not. That would be too harsh. We start with endocrine therapy, the pills. It has a similar probability of response compared to chemo, but a much, much better safety profile.
So you start with an AI, for example.
Right. We try one agent, say an aromatase inhibitor, and we use it until it stops working, until the cancer figures out a way around it.
And when it stops working.
Then we switch to another endocrine agent, maybe a drug called fulvestrant. When that stops working, maybe we try tamoxifen. It's sequential. You use up one lifeline, get as much time as you can from it, and then you move to the next one.
So when does chemotherapy come into play for these metastatic patients?
We really only use chemo in the metastatic setting if the tumor is hormone receptor negative, so the endocrine drugs won't work at all, or if the patient is in what we call a visceral crisis.
Define visceral crisis. That sounds serious.
It is. It means there are rapid, life-threatening symptoms in the liver or the lungs. If the patient is in trouble right now, they're having difficulty breathing, their liver is starting to fail, we don't have time for a hormonal therapy to slowly kick in.
You need something fast.
We need the fast, explosive action of chemotherapy to knock the cancer back immediately and get them out of crisis.
But even then, do you use those heavy combination chemo regimens like in the early stage?
Rarely. The philosophy is different. We prefer sequential single agents. We don't combine them because the combinations add a lot of toxicity without necessarily helping the patient live longer in this particular setting.
So you're protecting their quality of life.
We're protecting their Tuesday afternoon, their ability to go for a walk, their appetite, their time with their family. The source lists a number of agents like capecitabine, gemcitabine, vinorelbine that are often used one by one.
And what about the HER2 positive metastatic patients?
Trastuzumab is still the backbone of their therapy. We can combine it with another antibody called pertuzumab, which hits a different part of the HER2 receptor. We also have oral pills now, like lepitinib. We have a lot of tools in the box to keep these patients going, often for many years.
What about radiation? Does it have a role here if we aren't trying to cure the patient?
It has a very specific and incredibly important one, pain relief. If a patient has painful bone metastases cancer in their spine or their hip that is really hurting them, radiation is incredibly effective. The source says it's 90% effective at relieving that pain.
So it's not about curing the cancer.
It's about making the patient comfortable. It truly underscores that philosophical shift from cure to palliation.
It really does. Now, before we wrap up, let's touch on prevention. Can we actually prevent this disease from ever starting?
In some cases, yes. It's called pharmacologic risk reduction. For women who are at very high risk, those with strong family histories or known genetic markers, we can use drugs to lower their chance of developing cancer. Drugs like tamoxifen or another SERM called raloxifene. Studies have shown they reduce the rates of invasive breast cancer significantly.
That's amazing. You can take a pill to lower your risk before you even have the disease.
It is. It's called chemoprevention. Raloxifene is often preferred for this because it has a slightly better side effect profile, less uterine cancer risk than tamoxifen, but they both work. Even the aromatase inhibitors, like exemestane, have been shown in trials to reduce invasive cancers.
Okay, we have covered a massive amount of ground here. From the painless lump to the complexity of micrometastases, dose density, and that sequential strategy of metastatic care. When you look at all this source material, what is the synthesis for you? What's the one big thing you want a listener to walk away with?
For me, it's that breast cancer treatment is no longer and should never be one size fits all. It is highly, highly individualized. It depends entirely on the fingerprint of that specific tumor.
The fingerprint.
Is it ER positive? Is it HER2 positive? What is the nodal status? The evolution from the old days of just, radical surgery for everyone to today's world of targeted dose-dense biologic therapies has completely transformed survival rates.
It empowers the patient, allows them to walk in and ask, what is my fingerprint? Why are we choosing this weapon for my specific cancer?
Exactly. It turns the patient from a passenger into a participant in their own care.
I want to leave the listener with a thought that really struck me while reading all this. It's about that pivot point we discussed. In early-stage disease, the medical team acts with maximum aggression. They're willing to make you very sick with chemotherapy to buy you a cure.
Yes.
But in late-stage metastatic disease, they pivot entirely. Their whole focus becomes protecting your quality of life, minimizing toxicity, even if it means the cancer grows a little faster.
It's the paradox of oncology. To save a life, sometimes you have to risk the quality of it. And to honor a life, sometimes you have to withhold treatments that would diminish it.
It is. And the true art of medicine, it seems, is knowing exactly when that pivot must happen. And perhaps even more difficult, navigating that gray zone of survivorship.
What do you mean by that?
Well, even the cure comes with costs. Taking an aromatase inhibitor for 5 years means you now have to manage bone loss as a chronic issue. The cancer might be gone, but the management of your health, of the treatment side effects, that continues for years.
That is a vital perspective. The end of active treatment is not the end of the journey.
Thank you for helping us decode this incredibly complex landscape. Hopefully the next time our listeners hear these terms, HER2, adjuvant, metastasis, they won't just be scary abstract words. They'll be parts of a strategy they can understand.
Knowledge is the best armor we have.
That's it for this deep dive. Take care of yourselves, and we'll see you next time.